Good morning. Good morning to everybody. Today we'll revise the filtration process across the glomerular filtration and the various things that are related to the glomerular filtration. Now, if you see how the urine is formed ultimately, you see there are two processes that are basic. Glomerular filtration is the first step. Then, as the fluid filter goes into the tubular portion, then there is reabsorption or the secretion in the tubules. So, tubular reabsorption and tubular secretion can go on. So, glomerular filtration is the process of filtering leaving the glomerular capillaries and entering the Bowman's capsule. Now, I am not repeating the structure of the nephron, Bowman's capsule, etc., because you know about them already. So, the filtrate leaving the glomerular capillaries and crossing the visceral layer of the Bowman's capsule and the fluid coming into the capsular space. Then, when it is passing through the tubules, the filtrate in the convoluted tubules particularly will first they enter the convoluted tubules, and then there are peritubular capillaries. So there is some processing going on there. When reabsorption means the substance in the tubule is reabsorbed into the capillaries, which are now around the tubules. So we have one set of capillaries in the glomerulus and the second set around the tubular portion. So if there is further reabsorption, now you call it as reabsorption. Now here the filtrate is moving from the convoluted tubules to the peritubular capillaries. That is called reabsorption. Then there is also some amount that may be secreted from the capillaries around the tubules and back into the tubular lumen. That means by this process, some of the substances are removed from the tubular fluid into the peritubular capillaries of the blood. Then, similarly, the substances may be added to the convoluted tubules from the capillaries into the tubule. We are essentially dealing with the filtration part. What is happening in the glomerular capillaries in the Bowman's capsule? Now, glomerular capillaries, a single layer of endothelial cells with large pores, that is more permeable. What is this more? This is more than what is the permeability in the systemic circulation. You will find the filtration is very high compared to the systemic circulation. Then there is basement membrane, acellular gelatinous layer having collagen and glycoproteins. They have a negative charge, and no protein passes through that, because the proteins also have negative charge. Then, inner layer of Bowman's capsule, the visceral layer of the Bowman's capsule, the first is the capillary endothelium, basement membrane, and then Bowman's capsular inner layer or visceral layer. And this visceral layer or inner layer of the Bowman's capsule consists of porocytes with elonged feet, pedicles, and then there are some filtration slits in between these elonged feet. Then so the substance will have to pass through the capillaries to the capsule through this. So that means not only capillary wall is to be dealt with for the transfer of fluid and substances, and but we also have another layer of the Bowman's capsule. And there is some special arrangement there. A diagrammatic representation of the mass involved, Bowman's capsule, and this is the tubular portion. These are the capillaries, one afferent arteriole and deferent arteriole. What is coming in is afferent. What is leaving the capsule is the efferent. Then, as the capillaries are there here, you can see represented diagrammatically. Now, around that, the visceral layer is all present around those capillaries. So, squamous epithelial cells are here, and then in this portion, epithelium is there in the visceral cell layer. You can see this blue portion, you can say, this blue portion. So that is the epithelium from the glomerular, the epithelium from the visceral layer. The whole thing is called glomerulus. Now this is the space in the Bowman's capsule where the filtrate is coming from the capillaries into the Bowman's space. Then the capillary wall, apart from basement membranes, you have the endothelial layer, endothelial cells. There are fenestrations in between them. Fenestra refers to the window. That means an opening on the wall of the endothelial layer. This is the capillary side of the capillary lumen. Then the other side, where the Bowman's capsule's urinary space. Now, the basement membrane is in between, and then you have shown here, you're seeing here, the foot process of the podocytes. Foot process or pedicels of the podocytes, which are a part of the visceral layer. This blue portion. Then the urinary space of the Bowman's capsule. Now this is the whole thing is the filtering membrane. Mainly through this pores, the fluid is passing from the capillaries into the Bowman's space. Now further you can see the more realistic but still diagrammatic picture here. This tube is the capillary tube. So this whole thing is capillary tube. You can see those pores there. You can see the pores. So endothelial fenestra. You call the cells lining capillary as the endothelium. The endothelial cells. So there are pores in this endothelial layer, and the filtration of blood cells are not allowed. So it allows the components of the blood plasma to pass through. That also again some components will not pass totally across. There is another basal lamina basement membrane here. This bluish tinged layer. That one prevents the filtration of larger proteins because of the negative charge that it has. Then there are slit membrane between pedicels. So this is that membrane, slit membrane. So associated with the pedicels. So pedicel is this leg-like portion, extended portion that comes from the body of the podocyte. Podo refers to foot or leg. Then, so you can see podocyte of the visceral layer of the glomerular capsule or Bowman's capsule. So you have the filtration slits here and the fenestra in the endothelium. and there is basement membrane which is continuous and prevents the larger proteins going through it. So what goes from the plasma here in the capillary into the Bowman space is plasma. That means there are no cells, and then there are also no protein. So you can simply call it as the ultrafiltrate free of plasma proteins. So plasma minus plasma proteins is the composition of the filtrate. So when you come to the process again, ultrafiltrate lacks cellular elements and is essentially protein free. Why we say essentially? Yes, nearly the whole of the protein is not allowed. Maybe then some may slip away. The concentrations of salts and organic molecules like glucose, amino acids, etc., and the electrolytes, etc., are similar in plasma and ultrafiltrate. That's why we simply say protein-free plasma is the ultrafiltrate in the glomerular filtration. Simple. So these things are coming almost as it is, particularly depending upon their molecular weight or the size of the molecule. So all these things allow the movement of these molecules from the capillaries into the Bowman's capsule. Ultrafiltration is driven by Stalling forces. We'll see again what are the Stalling forces. We have seen earlier. These are actually questions on Stalling forces are very common, the shortcuts. So ultrafiltration is driven by the Stalling forces across the glomerular capillaries, number one. And then changes, that's the first part. So changes in these forces and in renal plasma flow alter the glomerular filtration. So anything that happens to Stalling forces and anything about the capillary membrane will affect the filtration process. So filtration of plasma occurs through glomerular capillaries into Bowman's capsule. This process is called glomerular filtration. How much is filtered? 20% of plasma that enters the glomerulus is filtered. That means 20% of plasma coming from the capillary path into the Bowman's capsule. The rest, 80% or so, will continue into the tube. Rest will continue into the tube. So that as it is. You can even say rest of the blood will go into the tube. Okay, glomerular filtrate. So what the fluid that was filtered, the ultrafiltrate fluid, which is filtered into the Bowman's capsule from the plasma flowing in the glomerular capillaries. So from these capillaries, it's coming to what is coming into the capsule, Bowman's capsule, is the filtrate. Glomerular filtration rate is another word, another term that you should remember very clearly and understand what it is. The rate at which glomerular filtrate is formed per minute. That means how much filtrate is formed per 1 minute. A unit time, essentially a unit time, usually used is per minute. So how much is formed? How much filtrate is formed per minute? In both the kidneys together, 125 ml of filtrate is formed. 125 ml of filtrate is formed, which amounts to about 180 liters per day if you calculate. Now, this means you don't have so much of fluid in the body as it is. So, further less will be in the blood vessels. And what is coming into the veins will be further less. So, what you need to do, what should be done is that the same thing is recycled again and again to get into this figure. Okay. Now, renal blood flow is about 1200 ml blood flow, that is along its cells. Of that, which amounts to about 21% of cardiac output. About 1/5 to 1/4 of the cardiac output comes into the renal, the renal blood flow. So a large proportion, nearly 1/5 to 1/4, is of the cardiac output is renal blood flow. So renal plasma flow of 650 ml happens per minute. Out of this 1200 ml, this is the plasma, this is the blood. The 1200 ml is blood, renal blood is flowing in the renal circulation. Out of this 1200, think of it. Then you will say 650 ml of plasma is flowing through the kidneys, 2 kidneys. Okay, now filtration fraction. What is filtration fraction? Simple. What kind of percentage you can see of GFR over renal plasma flow. So how much of this renal plasma flow has come as a glomerular filtration rate? That minute, of course, these are also per time. This must be per time. Either the plasma flow in the kidneys or the filtration rate at the glomerulus. So how much usually filtration fraction? GFR is about usually 125 ml per minute. While plasma, we already said that out of 1200 ml of blood, 700 ml is the renal plasma flow. So 125 by 700. If you calculate, it comes to about 0.16 to 0.12. GFR by renal plasma flow comes to about 1.16 to 0.2. Or simply, if you calculate, if you multiply by 100, it becomes 16% to 20% of renal plasma flow is coming in as the zero. So that is what it is. So this percentage, 20% or 16%, is called as the filtration fraction. Filtration fraction. The FF or filtration fraction. So filtration fraction is the portion of plasma that is filtered. Portion of plasma. So we are simply saying how much is coming to the performance fraction. So this is GFR by RPF, renal plasma flow, about 125 ml GFR and 700 ml the renal plasma. This is what we have mentioned earlier. The remaining 80 to 85% of renal plasma and also the blood cells continue on to the glomerulus into the efferent arterioles. So they have coming, this part is not coming to the tubule. This is continuing into the efferent arteriole and then further into the peritubular capillaries. Finally, this will be returned to the systemic circulation through the renal veins. Renal veins. Now, there are various factors that will affect glomerular filtration process. So, essentially, if you categorize them, molecular size and charge of the filter substance. Molecular size. So, bigger the size, difficult it is. Depending on what is the charge, negative or positive, also the filtration will vary. Net filtration pressure, this is very important. This is very important. We'll see one by one. Filtration membrane, area of the membrane, and its permeability. So if you look at the size, molecular size of the filter substances, you will see glomerular capillary membrane is also thicker compared to what is the capillary membrane in the systemic circulation. But it is more porous and so permeability is more. Full filtration rate is very high compared to systemic circulation. So anyway, now one of the factors that that will affect the filtration, molecular size of the particles or molecules. Substance, if you see, water, sodium, glucose, inulin, myoglobin, and albumin, and the molecular weight is increasing, the molecular size is also increasing. The lowest being water, 18 molecular weight, so, and the filterability, if you take it as 1, okay, for standardization purpose. Then compared to the water's filtration taken as 1, you see sodium and glucose also, they pass through, are filtered as good as the water. Even the inulin, though it is much bigger than sodium and glucose, it can also be filtered completely. But myoglobin, which is about 17,000, well, it can be filtered to a large extent, 3/4 you can say. That's 0.75 filterability. One means, say, one is 100%, so this will become 75%. Albumin is further bigger. Now, this is almost at the borderline size. Usually, this does not come into the filter. So, some small amount may leak. If at all, the small amount leaks, it makes 0.005 filterability. That's 0.5%, very small. So you can see various substances and molecular weight and the filterability. As the molecular size increases, filterability is decreased. Glomerular, and the glomerular nephritis, that is the inflammation of the glomerulus, damage to filtration membrane. And so the leakage of small size protein, as we said earlier, albumin is a small protein. Globulins are very big. So they will not come. If there is small amount of damage to the filtration membrane, then comparatively smaller proteins will come. So up to albumins may start appearing in the filter. So that condition is proteinuria, more specifically albuminuria, because albumin is the one which is leaking. Albuminuria. Albumin is also protein. So proteinuria also can be done. Now, charge of the filter substance. Now we said the basement membrane has negative charge. So that obstructs the passage of the protein molecules. So generally, the albumin, though it is capable of leaving, but still it doesn't leave usually because of negative charge of the protein. So albumin ordinarily even not filled as much as this. So when something goes back, then this to the charge, then you find something happens to the charge, then there is a leakage of the albumin first. And this one is charge we said, and the course of glomerular membrane is usually about 8 nanometers. Albumin's size is about 6 nanometers. That means molecular size is smaller than the pores. Okay? So it should come out in a way also. It doesn't come out because of this negative charge of the albumin, and the basement membrane also has similar negative charge. So it does not allow the passage of albumin or any protein for that matter. So restriction of albumin due to its negative charge and electrostatic repulsion by negative charges of the basement membrane's proteoglycans. Now, in the minimal change in nephropathy, even before the appearance of histological changes, that means even before you can see structural histological changes in the capillaries of the glomerulus, negative charges may be affected, may be lost. and that will cause the leakage of albumin. So low molecular weight proteins like albumin are filtered and they appear in the urine. So if the charge is decreased from the basement because of any damage, then you will find albumin is appearing in the urine, which is called proteinuria or albuminuria. So now we will come to the various pressures, and these are also called the so-called Starling's forces. There are two things mainly: hydrostatic pressure and colloid osmotic pressure. If you remember the osmosis, particularly, if there is a colloid like protein, then they, because of the osmotic nature of such substance, they like to retain water with it. They like to retain water in that particular compartment where there are colloids like proteins. So these are retaining molecules, water retaining molecules, or water retaining properties. Then if you look at the hydrostatic pressure is the driving force. It causes the movement of the substance or fluid across the membrane according to hydrostatic pressure. So, if there is hydrostatic pressure on the two sides, one side is driving, another side is opposing that movement. Obviously, both are producing this hydrostatic pressure. So each of them are trying to push across the membrane. So naturally, this one and this one are acting against each other. So somehow, if the pressure is smaller, then the driving force is weak. When it is more, then it is strong enough. So if you see a glomerular hydrostatic pressure, essentially the glomerular hydrostatic pressure is the capillary blood pressure. Nothing more to say. Hydrostatic pressure, we are using that term because the same kind of pressure is also used in the Bowman's capsule also. When you say Bowman's capsule, spares of the Bowman's capsule, then you cannot say blood pressure, isn't it? So we use the term hydrostatic pressure in either cases because the function will be similar, same level. So glomerular hydrostatic pressure in the glomerular capillaries is about 55 millimeters. Okay. Then in the Bowman's capsule, it is less. It is only about 15 millimeters of mercury. So as we said, this is opposing and this is driving because they are acting on opposing directions. Okay. Now this 55 minus 15, that is about 40 millimeters, is the pressure that drives the filtrate from this side to this side. But there is one more, glomerular colloid osmotic pressure. Now here, when you talked about hydrostatic pressure, you use glomerular side and Bowman's capsular side. Here you are only talking about the glomerular side. There is no Bowman's capsular side written here. Simple. The reason is the protein is not filtered, or protein is not coming into the Bowman's capsule. So there is no fourth kind of regulatory part. So you have protein, which is a colloid in the glomerular capillary blood, just like the blood in any part of the body. It has the proteins, plasma proteins are there. So glomerular capillaries have in their blood colloid osmotic pressure. You also have another term for this, oncotic pressure. Oncotic pressure. So, because the colloids are present in the glomerular capillaries as the plasma proteins. But in the Bowman's capsule, which is containing the filtrate, it is protein free. Protein free. So, there is no colloid osmotic pressure on the Bowman's capsular side. In the Bowman's capsular space. So that is not mentioned here. Okay. So, and what is this? What is the function of this colloid osmotic pressure? If there is an osmotic pressure, you are saying that osmotic pressure retains the fluid. So the colloid osmotic pressure is retaining the fluid. Retaining. So glomerular hydrostatic pressure is trying to drive. Bowman's capsular hydrostatic pressure is opposing. But this is big. It's pushing. Okay. Glomerular colloid osmotic pressure here is retaining. It is not allowing this to go. It is trying to retain the fluid. Retain the fluid. So this is also like something like an opposing. Something like opposing. So from the 40, which you got 55 and 15, 40, you deduct 30 millimeters of mercury pressure, which is the glomerular capillary colloid osmotic. So 40 minus 30 is 60 millimeters of mercury. So this is the net. Pluses and minuses all going, all sorted out, and ultimately you have about 10 millimeters of net pressure. And this is causing filtration. That means from the capillary to the Bowman's capsular side. So this is the pressure that is driving finally the filtrate into the Bowman's capsular space. So in this diagram, a very neat and clean and very simple diagram. Afferent arteriole, efferent arteriole. Incoming, outgoing, and then there are capillaries. So as the blood is going through these capillaries, then there is a glomerular blood or simply glomerular hydrostatic pressure. Glomerular blood hydrostatic pressure or glomerular hydrostatic pressure, which is 55 millimeters. Okay, so that is the driving force. Black arrow is the driving force into the capsular space. Capsular hydrostatic pressure. Here there is some amount of pressure, hydrostatic pressure. There is about 15. So that is opposing this force. So we can in the calculation we did 55 minus 15 came 40. Then inside the capillary, the violet, that colloid osmotic pressure in the capsule in the glomerular capillaries. That is about 30 millimeters. So you have 40. If this is solved, it comes 40. 40 minus 30, you are left with 10. Net filtration pressure. This is what you are talking earlier. So if you put this here, only the difference is he put the letter B also for blood. Okay, so that will clarify further more. Glomerular blood hydrostatic pressure. He didn't say blood pressure, just because there is a hydrostatic pressure on the other side. So this is capsular hydrostatic pressure. And blood colloid osmotic pressure. 50 minus 15 minus 50, ultimately net filtration pressure is 10 millimeters. So very simply, hydrostatic pressure in the glomerular capillaries, colloid osmotic pressure also in the capillaries of the glomerulus. So 50 here, we are deducting this force right away because this is what is working here in the capillaries. So 55 minus 30 is 25, and this is 50 opposing in the Bowman's capsule hydrostatic pressure. 50, this is 25 minus 15 is again 10. Okay, so virtually this diagram and drawn diagram shows glomerular capillaries, Bowman's capsule, hydrostatic, and the colloidal osmotic pressure in the capillaries, and heterostatic pressure in the Bowman's capsule. And you got the various values and ultimately net filtration pressure. Now, glomerular capillary hydrostatic pressure. How this is determined? Okay, this is hydrostatic pressure. So, arterial blood pressure, renal arterial blood pressure, okay, which is used for the development of the capillary hydrostatic pressure in the glomerular capillaries. Then there are arterioles, afferent and efferent, which can contract. So if they contract, they produce more and more resistance to the blood flow. Which, okay, so if they contract, resistance will increase. If they dilate, resistance could be less. So the arterioles also determine the hydrostatic pressure in the capillary. So here, increase in arterial blood pressure tend to rise glomerular hydrostatic pressure and the GFR. So if the arterial blood pressure is renal arterial blood pressure is increased, that increases capillary hydrostatic pressure in the glomerular capillaries, and hence GFR increases and the GFR rises. Okay, but then the renal blood flow has an auto-regulatory mechanism. So within a certain range of blood pressure, the flow is remaining constant because of the arterioles. One of the main parts is arteriole. So this auto-regulatory mechanism maintains renal blood flow. If the renal blood flow is maintained, glomerular capillary hydrostatic pressure is maintained, and hence, well, colloid pressures don't change just like that. Okay, so this is very important. This part is very important. So auto-regulation of renal blood flow will maintain the glomerular capillary hydrostatic pressure, which means the GFR is maintained within a certain range of renal arterial blood pressure, which is approximately 80 to 200 millimeters of pressure. Okay, afferent renal arterioles, constriction of afferent arteriole. Now imagine that arteriole is entering into the Bowman's capsule. So that arteriole is the afferent arteriole. If this constricts, then the resistance to blood flow is increased. So if the resistance is increased, renal blood flow, the blood flow into the capillaries will decrease. So if there is a reduction in the renal blood flow, GFR also reduced. Then dilated, the afferent arteriole is dilated, the blood flow into the resistance is decreased and the renal blood flow will increase. So GFR also will increase. Now, when you come to the efferent renal arteriole, there's a slight difference. Okay, moderate constriction, moderate fall in renal blood flow. Okay, then glomerular hydrostatic pressure increases because you have increased the pressure also. So GFR may increase to some extent. It will be moderate constriction. With severe vasoconstriction, then there is severe fall in the renal blood flow. Okay, increase in the colloidal osmotic pressure. And how is this? How is colloidal osmotic pressure increase? With the out of the blood, the fluid is continuing to flow into the efferent arteriole. Then the cells, etc., will remain in the capillaries to a larger extent, which means the cells as well as the proteins will remain in the capillaries, which will increase the osmotic pressure, colloid osmotic pressure. So this will decrease the GFR. So severe vasoconstriction, severe fall in renal blood flow, and this occurs increase in colloid osmotic pressure in the glomerular blood due to increase in plasma protein. Accumulation, you should use the word accumulation in plasma protein because the fluid has gone out through the efferent artery. So that will cause GFR, decrease in the GFR. Then come to the osmotic pressure. colloid osmotic pressure, or you can also call it as oncotic pressure. Oncotic pressure also. How much is that? The plasma, the proteins in the capillary blood will produce as much as 30 millimeters of mercury pressure. Now, if the passage of renal plasma loses water, then colloid osmotic pressure increases. So that's one thing. The factors influencing arterial plasma colloid osmotic pressure. This is one thing we have already. Hypoproteinemia. If because of the malnutrition, the plasma protein levels may be less. That makes hypoproteinemia. So colloid osmotic pressure is falling, and if colloid osmotic pressure is less, retaining power of the capillaries to retain the water, retain the fluid is also decreased. If it cannot retain, then it loses. So GFR is increased. GFR is increased. Dehydration. The dehydration also, what happens opposite? The colloid osmotic pressure increases because the dehydration, the fluid is less, the protein concentration is increasing, colloid osmotic pressure is increasing. Then the colloid osmotic pressure increases. What happens to the retention of the fluid? Retention is more, so GFR is reduced. GFR is reduced. And so all these things, they affect the fraction of plasma filtered by the glomerular capillaries. Now, come to the Bowman's capsule's hydrostatic pressure. Hydrostatic pressure in the Bowman's capsular space. So, in this, generally is about 50 millimeters, we already said. If there is any obstruction to the outflow, that is obstruction in the urinary tract, maybe because of the various stone formations, calcium or uric acid stone formations in the urinary tract, kidney stones also you can say, ureteric obstruction. If it doesn't cross the ureteric, then there is a back pressure. If there is accumulation of urine, there is a back pressure into the kidney. So that will cause this pressure increase. So naturally GFR will decrease. Prostatic enlargement, particularly this is the problem in the male. Prostate is the gland which is present just below the neck of the bladder, urinary bladder. So in the older male, when the prostate is increased in size, there is prostatic enlargement or hypertrophy, benign hypertrophy of the prostate, that presses on the urethra from outside. Presses on the urethra from the outside. So urethra is obstructed at the neck of the urinary tract. So that causes back pressure again into the ureters and into the kidney. And suppose there is edema of kidney inside the tight renal capsule. There is a renal capsule which is a fibrous kind of protection, and that doesn't stretch much. So if there is any edema, then the inside pressure is increased, and Bowman's space hydrostatic pressure also increases. GFR may decrease. Then when it comes to the colloid loss pressure in the Bowman's space. So earlier we have seen the hydrostatic pressure in the Bowman's capsule. Now we come to the colloid loss pressure in the Bowman's capsule. Ordinarily, there is no oncotic pressure in the Bowman's space normally because there is no protein filtered. But if there is some plasma protein is leaking into the Bowman's capsular space, then oncotic pressure will change in the plasma. So the oncotic pressure in the plasma changes in the capillaries, GFR. That means what is it will lose the water or the fluid. So GFR will increase. You can also say leakage of plasma proteins in the space. That means now the proteins in the Bowman's space wants to bring along with them some more fluid. So GFR increases. GFR increases. Filtration membrane, about the permeability part. essential. Reduction in surface area. For any reason, if the surface area of the filtering bed, filtering capillary bed is reduced, then naturally the function of the capillaries is reduced. So that will reduce the filtration or increase also if things are simply passing through the membrane, through the barrier. Increase the thickness of filtration membrane. If thickness is increased, then the filtration will be less. Then chronic uncontrolled hypertension, diabetes mellitus, they can bring about this kind of changes. Then one more thing is, if the age is going beyond 40 years, there could be about 10% decrease every 10 years. That means with the age, the number of nephrons are reduced. So as you age, number of nephrons will be less. Now we come to what is filtration coefficient of the glomerular membrane. KEF, filtration coefficient of the glomerular membrane. This coefficient is the function of the capillary surface area, which are dealt with. Then permeability. How big is the surface area? How good is the permeability? That's what determines the KF. So, with the filtration rate, GFR at 1 millimeter difference, 1 millimeter effective filtration pressure. So, okay, how much is the glomerular filtration? If there is a effective filtration pressure of 1 millimeter, that is the KF. Normally, that means the GFR filtered per a change of 1 millimeter of mercury pressure. Okay, so normally it's 12.5 ml per minute per 1 millimeter of mercury pressure. But then, how much is the net filtration pressure that we have earlier calculated? That is 10 millimeters. So 12.5 multiplied by 10 is 125 ml. Okay, or when you get the GFR and divide by the net filtration pressure, then you get the KF. This point we have mentioned that the renal blood flow is the renal plasma flow or blood flow is maintained over a range of arterial blood pressure. So arterial blood pressure is started here. So approximately around 70, 80. Okay, you'll see that there is no further increase with the arterial pressure. Here you have the slope. So say about 40 to say about 80 or 60 to 80 here. Yes, there is a linear increase in the renal blood flow and the GFR. Again, say coming to about 180 or 200, again the slope is upward for renal blood flow as well as the GFR. So in between, they are maintained stable. They are stable. So that's what it is. And we now come to a comparison between the glomerular versus systemic filtration. We have capillaries in both. So glomerular capillaries versus systemic capillaries. Smaller exchange area here, obviously, but here the whole body except lungs, large exchange area. But if you look at the rate, 180 liters per day, and this is just 20 liters per day in the systemic filtration. But most of it is taken into the system that immediately as blood flows. And now, of this 180 liters per day, only about 1.5 liters per day is excreted as the urine. So, GFR is 180 liters per day, and what is coming as urine is an average of 1.5 liters per day. Okay, so much of the 180, that means 178.5 liters is the real drop. Okay. So that's what that. And here also, whatever is not reabsorbed is reabsorbed by the fat. So then if you see KF is very high, about 50 to 100 times more compared to the systemic when compared to muscle capillary circulation, particularly. Because muscles have a good supply of capillary, particularly more capillaries will work during exercise. So compared to in the other part, yes. So here, the compared to systemic circulation, the coefficient, the fraction coefficient is filtration coefficient is much more in the glomerular capillary. So that's about glomerular filtration, glomerular filtrate rate, glomerular filtration fraction, etc. And I have not mentioned about the measurement of GFR, which you usually deal when you deal with the plasma clearance. If you calculate a substance like insulin for renal plasma clearance, you can find the glomerular filtration rate. A substance that is freely filtered at the capillaries but not reabsorbed nor secreted in the kidney. This is the essential feature. But there are some more characters also, right? It doesn't affect the metabolism in the kidney, it doesn't affect the flow in the kidney, things like that. That's fine. So most essentially, the three features that freely filtered. Okay, filtration must not be stopped, must not be affected. So freely filtered in the moment's capsule. Then in the tubule, neither secreted nor reabsorbed. If such a substance is measured, you can find the GFR by calculating the plasma clearance of that particular substance, and inulin is one of the usual material.